Hi, everyone, and welcome to Lehigh University's College of Health Colloquium series. I'm so pleased that you joined us today. I'm Beth Dolan, the Interim Dean of the College of Health. The Colloquium series this fall celebrates the Vince and Ellen Forlenza Endowed Faculty Chair in Health Innovation and Technology. It's a crucial faculty position in the College of Health, and we're conducting the search for this position this spring. So if you're out there and you're an expert in health innovation and technology, get in touch. We'd love to have you apply. Our focus this fall on health innovation and technology encourages our community at Lehigh and beyond to consider the ways in which innovation and technology can positively affect the health outcomes of populations. So we're collaborating this fall for the first time with Lehigh University's Baker Institute for Entrepreneurship, Creativity, and Innovation. So all Lehigh faculty, staff, and students who attend the colloquium are invited to attend the design thinking workshops, which we've dubbed the Opportunity Room, or OR, which will be held a few days after each event. So in those workshops, we'll have the opportunity to talk with one another about the problems each speaker identified that we feel inspired to devote our time and talent to solve. So I'll post a registration link in the chat so that Lehigh folks can sign up to join the OR workshops. The one that's coming up following this talk will be actually on October 29th, which is Friday, the Friday we celebrate Halloween. I went to the one last month and it was really fun. It was really exciting to engage in that design thinking process around ideas that were bubbling up in the talk. So just to give you a sense of the overall series, we have an incredible lineup of speakers this fall. Those of you who were here in September know that we hosted Dr. Karen Murphy, Executive Vice President, Chief Innovation Officer, and Founding Director of the Steele Institute for Health Innovation at Geisinger. She had an inspiring conversation about leadership and digital innovation in health with Lisa Getzler, the director of Lehigh's Baker Institute. In December, we'll host Dr. Stephen Tang, President and CEO of OraSure Technologies, a leader in the development, manufacture, and distribution of rapid diagnostic tests. That event will take the form of a fireside chat between Dr. Tang and Dr. Anand Jakota, the College of Health Associate Dean for Research and a professor of bioengineering in the College of Engineering. Today, we're fortunate to learn from Dr. Rebecca Jacobson, president of the startup Astrata, Inc., a digital healthcare company specializing in natural language processing for quality and value-based care. Dr. Jacobson will speak today about an incredibly important topic to all of us, measuring healthcare quality, why we are failing, and what can be done about it. She'll present during the first half of our time together today. In the second half, Dr. Jacobson will be joined by Vince Forlenza, retired CEO of Becton Dickinson and Company. In addition to asking Dr. Jacobson questions based on his extensive experience in the healthcare industry, Vince will weave your questions into the conversation. So please use the Q&A function you see at the bottom of your screen to post questions anytime. It can be during the presentation or during the conversation, and we'll do our best to get to most of them. So I want to tell you a little bit about both our guests before they get started. So Vince Forlenza recently retired as executive chairman of the board of directors of BD, Becton Dickinson and Company, which is a global medical technology company. He retired after 40 years in various roles in BD, culminating in his tenure as BD's CEO. As CEO, Vince led the transformation of the company from a manufacturer of medical supplies to a top 5 medical device, diagnostic, and life science company. Vince serves on Moody's Corporation Board of Directors and is chairman of the Valley Health Systems Board of Trustees. He's also a member of the executive committee of the Board of Trustees at Lehigh, and I'm really grateful to say a member of the College of Health's Dean's Advisory Council. So for the students out there, Vince majored in chemical engineering at Lehigh and then went on to earn his MBA at some school south of us. I think it's called Wharton. I'm not sure what university that's associated with. So it's also my absolute pleasure to introduce Dr. Rebecca Jacobson, our speaker today. If you joined us for the College of Health September Colloquium, you'll remember that our speaker, Karen Murphy, identified healthcare startups, particularly in the digital space, as one of 2 major disruptors driving innovation in healthcare. How appropriate and exciting is it then that we have the opportunity today to learn from the leader of one of those startups that is driving innovation? Dr. Jacobson is president of Astrata, as I mentioned, a digital healthcare company specializing in natural language processing, which is a crucial tool for harnessing large quantities of health data for the purpose of assessing and improving quality in healthcare. The company was born from her work as vice president of analytics at the University of Pittsburgh Medical Center Enterprises. For our students attending the colloquium, I always like to detail our speaker's higher education journey. So I'll do that now. Dr. Jacobson graduated with a BA in biology from Swarthmore College and earned her MD at the University of Pittsburgh. She completed her residency in anatomic pathology and a fellowship in neuropathology at Stanford University. She went on to earn an MS in information science at University of Pittsburgh. She joined the faculty in the University of Pittsburgh School of Medicine as an associate professor of biomedical informatics, serving as chief information officer for the Institute for Precision Medicine. After 16 years in the School of Medicine, she took on the role of vice president of analytics at UMPC Enterprises, and that came after 16 years as a professor of biomedical informatics. Dr. Jacobson's new venture, the quality startup Astrata, spun off from UPMC in 2021. So this year, their mission is to use their own words to help transform the way the industry measures healthcare quality, helping our customers achieve value-based care across all their populations. So please join me in welcoming Dr. Jacobson. This is where I really miss applause of being in person, so I'm gonna clap for her. So thank you, welcome.
Thank you so much, Dean Dolan. I'm really excited to be here. Very thankful to the College of Health for giving me this opportunity. Very excited to be here with Mr. Forlenza. Let's take it away. Let me share my slides first. Okay, that look good? All right. So, as Dean Dolan mentioned, I'm going to be talking today, really, I'm going to kind of give you a sense of what it's like to go from academics to a startup. And I'm also going to be talking about what is going on in this digital health transformation that we're in. I'm going to speak specifically about kind of how AI technologies, artificial intelligence-based technologies, things like machine learning and natural language processing, how they're impacting healthcare and the potential for impacting healthcare, and where we're falling short with them. And then I'm going to use my own company, Astrata, as a case study to kind of help unpack what is going on in this transformation. And we're going to talk very specifically about how we measure healthcare quality in this country, why that's really important, what we're doing right now, what's working, what's not working, and where we're going to have to go. And through that, how will technology disrupt and transform how we're performing this quality measurement that is so essential to moving to value-based care. And then we'll finish up by talking about some lessons that I've learned through this process, and then on to your questions. So thank you to Dean Dolan for that excellent summary of my career. I can't add too much more, but I do want to kind of unpack a little bit of kind of what happened, less about sort of what I did and when, and more about why. Because, you know, I made a transformation that lots of people are making in the old days of kind of academic medicine. When you got a medical degree and you went on to the faculty of a medical school, it wasn't that common to kind of go in and out of industry. There were a few people that did it, but it wasn't that common. It's actually not that uncommon now. People are moving back and forth with some much more kind of regularity as these pockets of innovation, whether they're in academics or in industry and sometimes even in government, are starting to kind of bleed into each other. So let me say a little bit about why, in terms of like the background of why I made these moves. So the first thing to explain is that I came out of my training. I actually did not only a master's in information science, but I did a National Library of Medicine fellowship in biomedical informatics, which at the time was kind of the way that you trained as a clinical informaticist. I did that, you know, more than 20 years ago. And at the time that I came out and became faculty, the world of clinical informatics, sort of the applications of computer science to medicine, it was a very small world. It was, 10, 15 kind of centers distributed across the country, where a lot of very innovative things were going on, but they didn't really get applied all that well and all that broadly. Things changed enormously around 2009. This was about 12 years ago, when of course, we had the terrible events of the sort of financial crisis at that time and the Great Recession. But as the result of that, we had the American Recovery and Reinvestment Act era. And at that time, the new legislation called high-tech, which was designed to develop with about 36 billion some odd dollars, billion with a B, that went on to develop a kind of to take electronic medical records and to make them actually distributed across the country. And they did this through a set of incentives. So they were really taking providers who were using kind of paper-based records, and they were giving them incentives to put in EMRs, electronic medical records, into their practices, and thereby to start to create this network of electronified clinical data. So all of the data that was being accumulated, collected through the practice of care, clinical care, was now going to be available in electronic form. This was imperative, an imperative part of getting us to value-based care. And when that happened, in many ways, it opened up many new opportunities. And I would say that in many ways, the innovation center of gravity for informatics, which had been kind of more academic at these kind of little places throughout the country, really started to move out into industry and in many cases into government with regard to policy. And it was no longer kind of this sleepy world that I remember kind of joining. And that was very exciting to me. At the same time, we had kind of the development of a real ecosystem of innovation. So as data became more available electronically, startups started to form. Healthcare systems and health plans and large organizations, including the big tech companies, started to say, well, it's time to invest in this. Now we have the data. So things like incubators were developed, where new companies could form and develop the relationships that were needed. And that's exactly what our company did. And I'll say more about that in a minute. So this ecosystem between startup companies, not-for-profits, incubators of various sorts, government agencies, et cetera, became a really important kind of infrastructure for innovation. And the last thing I want to say is that one thing, I should stop and say that it was really at this point that I made the decision that I wanted to leave my academic job and take a lot of the intellectual property that I developed in that academic job with my team, my sort of lab team, and to move it into sort of the real world. And that's the point at which I moved from my academic job to UPMC Enterprises and at one of these very incubators that I spoke of. And what I did want to add there is that one of the things that I found that has been so important to me in making both of these transitions, both from academics to healthcare and to healthcare innovation, and then to a startup that I'm leading, is the value of my scientific training. I can't really I can't overestimate the value of that training, because everything I do, whether it is on the side of creating innovations and new products, new methods that can be used and applied, or it's the business side of understanding how do I bring a startup from where it is at the very beginning to being a real force for change in an industry. Every part of what I do depends on my scientific training. So the work that you're doing as a student in your graduate programs and your undergraduate programs is crucially important, and you will use it every day. So let me say a little bit about where informatics, and especially kind of artificial intelligence and informatics, the potential that it has. And I think we are at a point where we are starting to see really amazing things beginning to happen. And really, in taking these methods from bench to bedside. So creation of the methods from computer science to impact on patients. And I'll point to kind of two sort of recent developments that I think are very exciting. Both of them happen to be in sort of cancer management and prediction. The first one is work from MIT, and this is the work on being able to predict from mammographies, which are read typically, they've been read by humans, to be able to use deep learning methods to predict cancer risk. And this work, I think, is really impressive because it has started as a computer science project, and it is being quickly tested and has amazing potential. In this work, the idea is to find lesions prior to when they are really recognizable, and also to be able to predict the risk of a particular lesion for a particular patient. On the right, what you see is a different kind of prediction, and this prediction is based on a combination of data, simple data, age data, demographics data, and it incorporates information that is kind of buried in a complete blood count. So this is actually predicting risk of colon cancer. And what I find so interesting really about both of these is that there is information, and in the second case, it's using these kind of parameters of a complete blood count to be able to predict, who should be screened potentially for a colon cancer. And again, what I find so exciting about this is that as we as a country are trying to get to values-based care, one of the most important things that we can do is not to be applying our screening indeterminately. We should be applying it to the people to whom it really applies the most. And both of these innovations, I think, have the potential to get us there. So this is a place where I think AI can have a really impressive impact on improving quality of care. But we've also had a long list of kind of retreats as we've had advances. And some of these retreats have been fairly high profile. And the one on the left, of course, is IBM's Watson, which was a system that was designed initially to kind of, it actually used some natural language processing. It was designed to answer questions. The breadth of what was attempted was probably too large. And you can read that excellent review in Stat News about what happened to that project. And there have been other projects, some of them going far beyond AI into kind of combinations of technology and healthcare that we have read have been shut down, including the two that I mentioned there. So clearly some successes and some failures. And I give these two examples, these two sets of examples as kind of like, on one end, the very small, highly targeted academic focus, and on the other, very large kind of industry scale, enormous initiatives. Somewhere in between, I think we have a better opportunity for success. And so that's what I want to talk to you about today as a case study. I want to kind of tell you about my company, what we're doing. We are kind of in the middle. We develop lots of methods, products around a bigger problem than just one specific thing. And the problem we've tackled is healthcare quality, but not as big as some of the initiatives that I just showed you. So before I start, I want to kind of tell you a little bit about where healthcare is going, both sort of economically and and why quality is important. And for many of you who are in graduate programs and undergraduate programs in the College of Health, some of these will be very familiar concepts, and hopefully you can kind of integrate these things into what you're learning. So the first thing, and this is something that I'm sure everybody knows, is that healthcare and the economics of healthcare are changing. We are moving from a more value-based method of a payment where providers would be paid for what they did, to value-based care, in which the idea is to keep our populations healthy. And that movement is very nicely summarized in this graphic, which I borrowed from, I believe, from CMS. And this shows shows that the movement, there are a number of different kind of alternative payment models. The important ones here are the ones that are purple and green, which are really the value-based models. And you can see here, and this is based on different lines of insurance. So whether you're covered by commercial insurance, if you're older and are covered by Medicare Advantage or traditional Medicare, or if you're on Medicaid. And you can see that this was as of last year, that the number of members, patients who are covered under these programs, is starting to be quite sizable. And we've seen it really kind of go up very kind of monotonically over the last few years. And the goals are quite ambitious. That is, CMS's goals are to get to 100% for the Medicare population and 50% for the Medicaid and commercial population by 2025. So how will that be done? Well, the first thing to sort of think about is, how do the health plans themselves, the insurers, how do they think about moving their populations as they are working towards these value-based care goals? And the idea here, which again, I think is probably highly familiar, is fairly simple. You want to take your populations, which are very heterogeneous and are probably sicker right now, and you want to gradually move them to be healthier over time. And you want to make them tighter over time. You want there to be less variability over time. And so health plans, insurers kind of have two main areas that they're sort of subsets and offshoots, but the two main kind of techniques that they have at their behest are risk adjustment, which is really kind of the way that they define the illness of burden on the population right now. And this is super important because they need to know, if they're going to get paid for a particular population, and one health plan has a very sick population, another one has a much healthier population, their payments have to be relative to the degree of sickness or health of that population. So it's a starting point. But then, of course, most importantly, they need a way to intervene and measure continuously. And this is quality measurement and also quality intervention. So this really defines the impact of the interventions that you're delivering to the population relative to your population health goals. So they have to be able to continuously measure and improve, et cetera, and gradually move their populations up. And in many ways, you can think of risk adjustment as kind of like being like a survey marker. It tells you where you are right now, whereas quality measurement is really like a compass. It tells you where you're going. It helps you to get to the right place. So the next question is, how do we measure quality? What are the actual what are the ways that we measure quality in this country? And for the most part, we measure quality through quality programs and using quality measures, yardsticks for how we are doing. And those yardsticks, the yardsticks that you use depend on the type of organization you are. So if you're a health insurer, like a health plan, you use one set of yardsticks. And if you're a hospital or a provider, you use different sets of yardsticks. And the goal is a little bit different for each of these sets of yardsticks. So if you're a health insurer, what you really want to do is kind of measure the overall quality at the population level. If you're a hospital, you want to measure quality of your hospital-based healthcare. And for providers, they often want to measure quality of a panel of patients, and sometimes they want to even measure quality of individual providers. So examples of these are shown below. And each of these programs, by the way, have their own names. And the one we're going to talk about is HEDIS. It's a health insurance program. But there are other programs like the hospital inpatient quality reporting, MIPS or MACRA for the providers, et cetera. Not that important to know the names. More important to understand what these quality measures really are. And so I've given you some examples for each of these. So for a health insurer or a health plan, an example would be, what is the percentage of health plan members 50 to 75 who've been screened for colorectal cancer? For a hospital, it might be something like, what percentage of patients who have received DVT prophylaxis for deep venous thrombosis, it's a risk of being hospitalized in this hospital. And for a provider, it could be something like, well, let me find out what is the percentage of the providers of diabetes patient panel, that is a set of patients who have diabetes, who had a neurological exam of their lower extremity in the last 12 months. So these are all yardsticks for how well we are delivering healthcare. And I want to point out a few things about them before we go on. The first is that very typically, these measures have a numerator and a denominator. It's not true of all of them, but many of them, probably the majority of them, have this kind of numerator and denominator, where the denominator is the population of interest. Could be everybody, could be the diabetes patients, et cetera. Could be the patients who are hospitalized. And the numerator is an indicator of compliance. How many members have had the right thing for that measure? The second thing to point out is that there are different types of measures. So there are what's called process measures, and then there are outcome measures. Process measures are useful because they kind of give you an indicator. They're almost a sort of a leading indicator of what may happen in the future. The really powerful measures are outcome measures. We want to know what happens to these patients. Are we able to keep them healthy? And right now, many of our measures are really process measures. And so what we want to do is to get to outcome measures. And the third thing to understand is that really the whole idea in value-based care for these measures is that the incentive payments that you may receive as a health insurer, as a provider, for a hospital, et cetera, these are based on these measures. So the idea is really the better you get, the better you will do financially. And that really links two important things: the outcome, the health of the member or the health of the patient, with the financial interests of the organization. So the next question is, how do we do this exactly? What's important for getting to value-based care from the perspective of measurement? So I want to talk about three things that are important to understand. The first is this idea of a learning health system. And the second is the importance of interoperability and healthcare data interoperability. And then finally, and this is where we're going to kind of move into talking about Astrata. Let's talk about what is this move to something called digital quality, and why do we need digital quality? So first, the concept of a learning health system. And again, this may be something, learning healthcare system. This may be something that you are already familiar with. Learning healthcare systems, this is an idea from that was originally kind of proposed by the Institute of Medicine. I think it was maybe 2006, 2007. And the idea here was that our old way of getting kind of evidence through randomized controlled trials, et cetera, that method, while great and worked well with the kind of data that we had, was insufficient with the amount of data that we've got and with our need to proceed using more kind of observational methods, et cetera. And so this idea of the learning healthcare system was really like, could we take a much more iterative approach to learning from our data, making change, and improving healthcare? And the idea is to really systematically gather and apply evidence in real time to guide care, to analyze data and care experience to improve healthcare, and very much based on the use of information technology to share new evidence and to collect it and to analyze it, and to refine those processes and basically create a virtuous cycle of learning from data and applying that data to the care of our patients. So for those that are familiar with kind of plan, do, study, act cycles, it sounds just like that. It really is kind of on a broader scale. And I wanted to take a minute to think about, kind of collectively think about, what are the important aspects, the important characteristics of feedback that helps us to make this cycle go quickly? And for the students in the audience, you can kind of use your educational experience as a bit of a touchstone here. What kind of feedback helps you to get better in your classes, for example? So I would suggest that the 4 critical things that you need in feedback, whether it's for a student or for a healthcare system, is that you need it to be timely, you need it to be actionable, it must be accurate, and it has to be efficient. In other words, it can't be too expensive. So, for example, we can imagine that if we were giving feedback through a healthcare, to this learning healthcare system, and it came 2 years after the fact, it might not be very valuable because I may not be able to make that much change based on information that's 2 years old. Similarly, it should be actionable. I should have information about all of my patients or all of the members for a health plan. Third, it should be accurate. I should actually know what is the state of these measures on every member. Like it has to be true information. It's not very helpful if it's not accurate. And finally, I can't afford really, as a healthcare system, given our costs in the US healthcare system, we can't afford a very expensive answer to this question. The second topic we need to talk about is interoperability, because part of the challenge that we have in improving healthcare is the fact that healthcare is extremely fragmented in this country. And because of that, I may go off and see a provider. Look there on the very left, you see a patient outline. I may go off and see two different providers and also go to a urgent care, a hospital, and that data is going into multiple different EMR systems. And yes, those EMR systems store that data, but for the most part, they have not been interoperable, able to exchange that data. And consequently, it's very hard to know sort of the true state of that patient because that data is very fragmented. And the way we've kind of gotten around that to date is, and especially true for insurers, health plans who are key to this value-based care, is that we've used claims data. So data that it comes out of the EMR for billing purposes. And even though the EMRs may be holding on to all that data, they're also sending claims requests, billing requests to the insurers. And those claims actually do contain a lot of very, very useful information. Things like what procedure was done, for instance, and what a particular diagnosis may be. But there's a lot of other problems that are associated with it. Typically, it's not at the right level of granularity, and there's a lot of missing data. And it's missing because healthcare is fragmented. I may have one insurance plan 1 year and another insurance plan another year, and the data does not necessarily flow between the insurers either. Now let's begin to talk about how quality is measured in this country. And you can really think of the programs that we talked about, for health plans, for hospitals and providers, as having another kind of axis, and sort of orthogonal axis, which is what your kind of insurance is, whether it's Medicare or Medicaid, et cetera. And there are bonus programs associated with these programs. They're bonus incentives, quality bonus payments that come from the federal government largely, also through the states, that help to make that move of your populations. And those programs are associated with these very types of quality measures. And of course, we have to have some national quality infrastructure in order to do this, to be able to compare all these things and get the right incentives to the right people, et cetera. So what does that look like? Well, in many ways, if you went down to kind of like the oldest building you could find and look in the darkest corner and you find kind of the oldest piece of equipment, I would say in many ways, that's what our quality infrastructure, quality measurement infrastructure in this country really looks like. It is truly antiquated. Why is that? The way that we measure quality in this country at the health plan level, for sure, is composed of two things. We already talked about claim data. That's a very important part of how we measure quality. And that's done on kind of a monthly churn, and the data is reported a year later and often 2 years later for some of these programs. So it's not very timely. The second component of it is actually that once they realized that this claims data was not very helpful, actually, because you were missing a lot of members, a lot of important data, they began to allow the health plans to do manual record review. You could get a chart and you could have a nurse look at that chart and you could say, well, that's actually an indicator that this member has had the right thing done. And so that addition of medical record review on a small sample of members was added. And it's really those two things, the claims logic and this manual record review that is done on a sample that constitutes our national infrastructure, distributed infrastructure for measuring quality at health plans. So this is just sort of a graphical interpretation that we take from these large populations a sample. That sample is used as an addition on top of the claims logic to measure those rates. And that really is part of our big problem that we have. Both of those things really are not generating timely, actionable, efficient, I forget what the fourth thing was. It's missing the mark on every one of those, what was that? Sorry, gotta go back, it'll drive me crazy. Timely, actionable, accurate, and efficient. So unfortunately, right now, what we have is none of those. And this is why CMS and the states and the National Center for Quality Assurance are trying to change how we measure quality and to move it from its current state, which is basically very paper-based and manual, to something that's called digital quality. So we will go from having manual, largely claims-driven, retrospective, end of year, and on a sample for many measures, types of quality measures, to having something that is automated. It's using data from EMRs. It's prospective and continuous. We're doing it on everyone, not just 411 of the members for a population. And this is what can really fuel a learning health system. So the challenge here, of course, is that it's fine to be measuring, I'm going to only talk for the next part of the talk. I'll only really speak about that medical record review part of it as I tell you about our natural language processing systems. But it's fine to be reading, getting a chart, sitting down, reading the chart, determining whether that member has met that measure. That's fine if you're doing 411 members for each of these measures for each population. It's very different when you have to do that across a whole population. It's actually not possible. It is an intractable problem for humans to be reading that many charts. They can't read millions of charts at one time. So how do we do that? In order to make it timely and actionable across a whole population, we really do need some form of technology in order to avoid this problem of it being so expensive that we would not be able to actually, deploy it and use it. So we could actually just employ, 10 times the number of nurses to actually go in and read these things. It just wouldn't be a very efficient thing to do. It's not going to work. Okay, so now we got to the story about Astrata, which, as Dean Dolan mentioned, really creates products and services that transform the way healthcare quality is measured. And I'm going to share with you kind of one of our stories. We actually have a number of different innovations, but I'm going to share with you one of these innovations, which uses natural language processing. So what is natural language processing? I know there are some analytics graduate students here. You have a program in that and healthcare analytics, but I'm going to just give you kind of a very simplified version of what that looks like. So you can imagine a piece of clinical text. This is something that would come out of, let's say, a visit to the doctor. And it might have some sections. And so I'm showing you some sections here. CC means chief complaint. That is when the doctor says, what can I do for you, Mrs. Jacobson? Your response is going to be entered into the chief complaint or some version of that. And family history, screening, and there's some data from a physical exam. Now, this is, of course, a kind of a caricature. It's a little bit of a cartoon note here, simplified to make it easier to talk about things. So when we use natural language processing techniques, we're really basically applying a series of computer-based methods. And we'll talk more about those methods in a second, but the idea is a sequence of methods, and we're gradually building up more and more annotations on this simple text document. So the first thing we often want to do is to detect sections, because those sections have important, relevant contextual information. So maybe we say, well, this chief complaint, it's one section, the family history is another section, et cetera. And then the next thing we want to do is to determine, what things here are punctuation, what are letters, what are numbers, what are spaces. It's called tokenization. Next, we want to break apart within each section the sentences. And that's important, as we know, because the sentence tells you what the boundaries are for that thought. So you don't want to necessarily, well, sometimes you do go across different sentences, but in other cases, you may want to focus your reasoning on an individual sentence. One of the problems with clinical text and clinical notes is that the sentences are not like kind of prose sentences that you read in a novel, for example. Next, we need to recognize different concepts. And so here you can see there are different symptoms, diseases, procedures, observations being recognized. We have to map that to a vocabulary. And then we want to recognize modifiers. So for example, here we have some descriptions of colon cancer, but in some cases, this is actually a family member that has colon cancer, not the patient. So we want to know who the experiencer is. And similarly, we want to know, is the provider certain about this? Is there any uncertainty? Is this something that is present or absent? That is negation. And temporality, what is the temporal relationship? Is this something that was a past problem, but is no longer a problem, et cetera. So all of these are important aspects of what we do. And in the end, we basically take all of this information and we extract all of the relations to be able to do a kind of natural language understanding where the machine is able to understand the meaning that is in the text itself. And that often requires us to do some fairly sophisticated things. We have to know what is the sense of a word. It could be the same word that is used in different senses. We have to extract information that's in tables. We have to deal with things like misspellings and acronyms. If this note says MI, is that talking about a myocardial infarction, or are we talking about the state Michigan? So all of this is part of what we do in natural language processing. And we often use a mix of semantic methods, which are linguistic methods, and statistical or machine learning methods. Most systems use both of these. How are we taking this method and applying it to the quality problem is the next series that I want to go through. So the first thing is we're a company, we make products, and that's part of our innovation. We develop methods in natural language processing, but that's not very helpful if our customers can't use them. So part of what we do is to create actual products that people use. Now, I was speaking about these very nurses that do the abstraction. Well, typically they sit down at some form of an interface where data is in the EMR, and they begin to say, well, for this member who has a gap, a particular measure that they have not been compliant, can I find evidence that they actually have been compliant? Because they want their data to be accurate. They want to give providers the right information so they can go make change. So what our system does is something extremely unique, which is we basically take all of that data and we run it through our natural language processing system, and we tell a abstractor, a nurse who's reading a document, a whole chart, we tell them, we think this one you can close. And that's what a hit is called. This is sort of lingo from this industry, so you'll just have to ignore that. Hit means basically, this is someone who meets the numerator. They're in the denominator, they meet the numerator. This is a compliant member that you would otherwise not know is compliant. And then there are things like exclusions, I won't get into that, and leads, a member where maybe a lot of information suggests that this member is compliant and we know you want to close this one. There might be some extra things that you have to do. Why is this important? Because when I showed you that you have to move to a population, where instead of abstracting 411 cases, you might have to abstract 40,000 cases. Now you need a way to know in advance whether you can actually close that case and determine that that member is compliant. And so this is the technology that helps you develop that strategic efficiency, that helps you prioritize and spend your time only improving your data on the ones that you can improve your data on. Additionally, we summarize all the data. So instead of looking through 1,000 notes, we are going to take that nurse abstractor directly. We're going to bubble it up to the top, give them a button to push, and take them directly to where there is evidence that closes that gap. And in this case, you can see a gap as CDC means complete diabetes care. And this is a particular submeasure. And here you can see that we have evidence that a medication is in the medication list that meets the requirements of the national regulator for this particular measure program, and NCQA's HEDIS program. And all of that is summarized at the top of that bar there. Now, accuracy. Accuracy, as I said, is critically important, and measuring accuracy in NLP systems has a very specific science to it. So you can imagine a note that is shown on the left there. The patient refused colonoscopy. And maybe, so a colonoscopy is an exam that you have to reduce your risk of subsequent colon cancer. It's a scope exam of the colon. And maybe there's another note later on that says the patient had a C-scope on May 5th, 2018, but the exam didn't reach the splenic flexure. It wasn't actually a complete exam. And then finally, it says Colo 8/2018 at the Cleveland Clinic with hyperplastic polyps. So the good news is this patient first refused the exam. Then they had an exam that was not actually complete and therefore should not be counted. But finally, they did have the right exam, and it's within, and this member actually is compliant. So when we look at the level of the document, our NLP system should be able to recognize that if it says the patient refused colonoscopy, that's not really a colonoscopy. And it should know that C-scope and colo are synonyms of colonoscopy. And it should further know that a colonoscopy that does not get to the splenic flexure actually is not a complete colonoscopy, and it shouldn't be counted in that numerator. So using these kind of performance at the level of the document for a measure, we can determine what the system did, whether it's true or false, against what a gold standard is. This is usually, real nurses, abstractors who are going to say, this is positive, this is negative, et cetera. And that confusion matrix of true positive, false negative, and usually we don't measure true negative, but sometimes we do. That defines your performance metrics. And in NLP, those performance metrics are precision or positive predictive value and recall or sensitivity. And we often use a mean of those two, the F1. Accuracy can be measured in lots of ways. And I want to say just a few minutes about that. You may be measuring your accuracy against a gold standard in a lab, or you may be measuring your accuracy in the field. And those are two very different things, because real world accuracy, often you find that there are many other things that impede your accuracy, that impact your accuracy, that are not accounted for in a laboratory. So being able to measure real world accuracy is really, really important. Furthermore, and so here are some examples of kind of, what does precision look like for these NLP systems? Here are different measures, some of which we discussed, and here are the accuracy of the system. This is precision, a measure of false positives. One is perfect, that show that these systems are able to get up to very high accuracies, high enough that they are comparable with humans. Another key point is that accuracy alone is not really what gets you to the finish line, because really we're trying to change healthcare. And so what we really care about is outcomes. And outcomes, or key performance indicators, are even more important to measure and to understand and the impact of your technology. But you need to measure them at the right time. So for instance, we might say, well, how efficient are abstractors? I mean, if I used a system that did what you showed me, could I get my abstractors to, be able to use to abstract across a population? Do they really get more efficient compared to not using such a system? Or what's the impact of this process on quality rates, for example? Or what's the impact of the technology on patient outcomes? These would be more outcome kind of based measures for technology. Let me show you some examples. This is data that comes from UPMC, and it shows our system, and this is in actual use. This is this year, showing different weeks of what we call year-round review. That is them applying our technology over a population, and this is in the first 14 weeks. And you can see the blue line is how many gaps they're able to close, and they're predicting they're going to get to about 25,000 this year, which is to them an extraordinary number, because the orange line is what we predict based on previous data that we received from them about how they do this. And that shows you what they would be able to do without the technology. So this is in a graph, the power of innovation. It makes it possible to do something that was intractable, and to make it possible to do that across the whole population. And that is a software that's actually embedded in the workflow to help them to work at the top of their license. They're not necessarily going to be doing this forever. What we want to do is gradually start to automate this so that the humans focus on the most difficult cases and the system handles a lot of the easier ones. This makes this data, so the ability to use NLP across the population means we can make this data actionable. Instead of reviewing 411, now we can review all 40,000, and that means you have data on individual members, on individual patients. And then finally, it's efficient, because these systems, the way they take effort and time to create them, they're very scalable. We can put them into the cloud, we can use them on billions of documents, and it does not cost incrementally what a human being costs. These systems often work better in that kind of combined way, that the NLP and the humans often do better than the humans themselves in two ways. So the first thing, and this is data that came from UPMC that showed that actually not only did the abstractors, these nurse abstractors, get more efficient, but in fact, they were able to find things that they didn't find before. Why is that? For a couple reasons. First, it turns out that, and this is widely seen in any complicated human-based task where you have some very complicated schema or specification, and they have to take something like a medical record and determine whether that specification has been met. Any task of that complexity, there are often pockets where the humans do not do well, because it is a very difficult task. And one of the places that they don't do well is finding things, because if you have to go through a medical record of thousands of pages, you're going to start by looking at the places you think that you're going to find data, and you're usually going to miss a lot of places where there may be data that you would not normally look for. So that's one thing. The recall or false negatives of the humans is often quite substantial. It's usually more than systems that are good. The second thing is that humans tend to drift. That's the other thing we see in these sorts of tasks. It's inevitable. You learn the specification, and the next day or the 3 weeks after that, you forget the details of it. And that's something that computers can become and technology can get very good at. It can describe exactly what that is and apply it in the same way every day for the next year. So that drift is something that we can also measure, and we measure it by looking at the false positives. Our system says that it was a hit, that member is compliant. The abstractor who's doing that case says, I don't think so, that's not a hit. Well, we look at those hits and we see what are the false positives. You know, the system said it was good and the human said it was a false positive. And many times what we find is that we find that the human is actually the one that's an error, because they are applying a logic which is not exactly what the spec says you can do. And that's where the system and the human get kind of out of sync. Finally, I'll tell you a little bit about how do we actually impact, how does this actually impact patients? Mostly what I've described to you is the impact on getting better documentation. And that's important. It's important for the financial health of a health plan or a provider who's in a value-based care arrangement. It's also important because having accurate lists of who you have done the right thing and not done the right thing means you intervene on the ones that you haven't done the right thing for, and you don't have to intervene on the others. But there's another way that this technology impacts patients, and that is to turn it around. Instead of measuring who actually has a care gap, something that we expect to be done, that it's already done, that it's kind of in the clinical note and a little bit buried away and we can't get credit for it, let's turn it around and say who hasn't had that thing done. And let's try to do it in a much more timely way. So this is an example, again, from UPMC, which shows how our company partnered with that health system and health plan to try to move a measure that was very difficult to move, very difficult across the industry. And that is interventions for women who have osteoporosis, unknown as yet, who have a fracture. So the idea is an older woman has a fracture and they need to be screened for osteoporosis and they need to be treated for osteoporosis if they have that disease. And if we don't do those things, then they're at risk for subsequent fracture. And actually the likelihood that they're going to get sick, that they're going to end up in a nursing home for some time, perhaps forever, that they may die prematurely, those all go up substantially in this population. And the bad news is, and this is a surprising number, it's really amazing in my mind, only 20% of women with osteoporosis who have a fracture get tested and treated within 6 months. Part of the challenge with that is that that archaic system that we have. Are you all there? Okay, good. You froze for a minute. Always a scary thing on Zoom. That archaic system that we have, that I showed you with health plans and the fragmented nature of data and things coming in through claims, what happens, unfortunately, is that a member may have a fracture, go get it, get the fracture taken care of, et cetera. But that information never really makes it back to the health plan until maybe 3 months later, when that claim appears. And then the health plan is kind of in some ways in charge of getting that information back to the primary care provider, because the information hasn't really kind of filtered back because it didn't happen. You know, the primary care provider didn't actually take care of the person while they had their fracture. And that process takes a long time, so it's not timely. So what we did is we took our NLP system and we basically just said, okay, if we can tell who has actually, who's in the numerator, we can tell who's not in the numerator. And we took their standard process, that is the health plan waited until they had a claim before they contacted the member. And we actually sped that up by quite a lot. So they went from 57 days to 9 days. As soon as the member had a fracture, we knew about it. We detected that they were not in that numerator. We notified the person at the health plan, and the health plan went out and started to try to make change to intervene with those members. So using their standard process, only claims data, they reached about 50%. That's kind of a normal amount to reach, unfortunately. But only 39% of members actually could be scheduled for the right intervention. Whereas when we did this much earlier, we were able to get to about 59%. And that increase is honestly, in many ways, only because it has nothing to do with the NLP. It's only because they're getting the data at the right time and they can intervene with the patient at the right time, at the time when they actually are amenable to get the intervention right after the fracture. So let's talk about some lessons. So the first thing that I talked about is that the learning health system and the creation of a real learning health system in our country requires feedback that is timely, accurate, actionable, and efficient. And our national measurement apparatus as it exists today, which is, at the health plans, that is claims and medical record review manual on a sample, is really failing us. And the health plans are very, very important, as I mentioned, to the measurement of quality because of the fragmented nature of healthcare. So that really needs to change. The good news is there is a lot of movement afoot. And I think that quality measurement is going to look very different in 5 to 10 years. We will go from being a largely paper-based manual system that uses claims data and a little bit of medical record review, to having that data now begin to be used by insurers and more globally, therefore, by the providers who are getting that data from the insurers in a way that is much more interoperable and will allow us to make transformative change. The technology and the kinds of technologies that I mentioned, including the kinds that we use in our own company, Astrata, those technology innovations that use advanced analytics, natural language processing, machine learning, built on these interoperable frameworks, they can help us to achieve this learning health system that we're looking for. The other messages that I gave you are that humans and AI together are often better than either one of them alone. We don't necessarily have to pick. We can use them both together. And finally, one message that I have learned loud and clear is that it's not just about the technique that you're using. It's not just about that basic science of being able to get the right model, the accurate model, the one that tells you what is the prediction that you're looking for. You really have to embed technology in products, in workflows, in business processes in order to have impact. And so that's something that we think about every day. With that, I am done, and I would like to open this up with Vince to your questions.
Professor Jacobson, that was a wonderful presentation, just absolutely fascinating. And let me just say, I've seen the move to AI in anything that's image-based, and it's moving very, very quickly, whether it's microbiology, pap smears, or breast cancer. But the language piece of this is enormously difficult. So very exciting to see this moving ahead the way you're describing. Let me try to prioritize questions from the audience here. I'm going to start with one, which is a little broader than what you were talking about, but I'm going to take it and relate it to what you're talking about. And the question is really about, does an employer-based insurance system hinder movement to population health from fee-for-service? And of course, what they're really talking about is people shopping, changing companies. And then you've got this issue of, does the insurance company get the payback and what happens in the longer term? And does that mitigate the movement towards the sort of system that you're talking about? Or do you see this going quickly also on the private side, not just the government side?
Great question. There's a lot to unpack in that question. Let me try to hit on some pieces of it, but I probably can't hit on the whole thing. Yeah. I think that for sure, the way that the US health system works right now, of course, it's incredibly fragmented. Someone changes employment, their insurer changes and everything changes. And that inhibits our ability to find out what is kind of the state of the patient, of the member at that time. I think that a lot of what the Office of the National Coordinator, ONC, is doing with these new interoperability rules, and these are relatively new, they come out of the sort of, I think it's 21st Century Cures Act, requires health plans to actually begin to interoperate. And they're doing that at almost sort of a laughably small level at the moment. They're doing things like being able to exchange information about who the providers are at a health plan. Now, if any of you who have tried to figure out how to get a particular provider at a health plan, that is not so easy, that is associated with your health plan. So that's the level of the interoperability at the moment. But I think ONC and CMS recognize that interoperability is key, that maybe we're going to change to a different type of healthcare system, but probably not. We're probably going to be stuck with the one we've got. And that the answer really is in interoperability. So I think that's where the push will come. And that with time, we will begin to exchange much more data in a way that is meaningful and that gets us to the ability to do these measurements. And I think it will impact commercial health insurance eventually, although for sure it's going to hit the government programs first.
That's great. And there's a big advantage to folks who have bigger databases in doing this. So the government is going to have a huge database. So there'll be a lot of incentive as this moves forward, more and more incentive as this moves forward to share data, because otherwise you're going to be lagging behind. So
that's right. It really does snowball. Yeah.
Interesting. So here's another really interesting question, which is, it's known that when entities are incentivized based on metrics, they will optimize those metrics, and often at the cost or the spirit of what you're really trying to accomplish. How do you think about that in the context of what you just went through in terms of moving to outcomes-based metrics?
Yeah, that's another great question. For sure, people will they'll think about what is the test and how do I get around this? There's just an innate, just the way that organizations and institutions work, for sure. I think part of the challenge has been, honestly, that in the absence of very good measures, and I would argue that we don't have very good measures at the moment. I think in the absence of that, it makes it much easier to want to kind of game the measures, because you look at the measure like, control of blood pressure is such a great example. And the measure is the last blood pressure of the year compliant? Now, you can imagine all kinds of ways to game that measure, many of which are really, antithetical to good clinical care. I think when you have bad measures, bad process-based measures, they're almost, they almost open the door. They make people want to game them, basically. I think it's a lot harder, and people will be less likely to game the outcomes-based measures.
Yeah, I certainly agree with that. So there's some questions around what are some of the real obstacles that are in the way of implementing this? And I'm going to push it not towards the technology side, but the cultural side of this.
Yeah.
And so, you have, like, when I say providers, I'm talking about doctors. And how do you see, their willingness or reticence to do this? And what I'll talk about for a second is, historically, you start putting in standardized care and they say it's cookbook-based care and whatnot. So how do you see that whole thing interacting with what we're trying to do here?
So I think what we are doing right now, kind of what we are focused on right now, which I've just shown you, is extremely acceptable to providers. They love this, right? Because this gets them closer to an accurate rate. They get credit for doing the things that they do without necessarily having to go and, hit every drop down box. Because for the most part, providers don't like EMRs. They hate them, and they would much rather dictate a note, because they could do it much more quickly, and they can be more expressive, and they can say what they want to say. Right. So generally what we're doing, I would say the providers generally like. Now, what you're hinting at, I think, is actually extremely important, that has not been done in any real way there now, but I think it's coming. I think you're right, Vince. And that is to begin to line up the measurement with the clinical decision support.
Yes.
And for now, and the great thing about the technology that is being pushed by CMS and NCQA is that it actually makes it possible to do that, although we are not doing it. And I think it's going to take a while to actually do it. When that happens, if the question is, will this incur frustration and resistance among the providers? The answer is yes. It definitely will incur frustration and resistance. On the other hand, I think it's actually critical, because the amount of information that goes through a provider's hands at this point, and the number of patients that they are really kind of required to take care of, and the economics of the whole thing are such that they actually probably cannot do the right thing without this information.
Right. Excellent. Coming to something that you talked about, you talked about the interaction of, using the system, the AI, and human judgment, and going back and forth with that. Can you talk a little bit more about it? I think you were just mentioning it there, but how does that, if you get that right, what does that really look like?
Yeah. So, for our system, I'll just give you an example, but there's tons of other examples out there. For our system, what that looks like is if we have a population of 4 million members and we have to go and figure out which of these members, have we done the right thing or not done the right thing for? What we want to do is make it possible for the vast majority of that data to be determined. The vast majority of members, we could determine that with our systems, with our AI systems. And let's say we could do 90%, that'd be great, or 95%. And that's work that doesn't have to be done by the humans. And we can do that for that 90 or 95%, we can do that with very, very high accuracy. There is going to be cases that we can't do at very high, because they're very complicated and our machines aren't able to do that. Right. That's the data that we want humans to look at. And so by getting humans to kind of, like I said, sort of work at the top of their license, be the real clinical expert that figures out what is going on in this complicated case, right. Then we are using what humans are really good at. And we're not asking them to go and read 40,000 charts. So right. That's an example.
I would just add to that, if you look at what's happening in the imaging space, it's exactly what you're talking about. You're Absolutely. Getting rid of all of the quite clearly negative, and yes. You focus on the ones that are questionable. And that's where you spend your time. And it's improving care, in my opinion, dramatically. Yeah,
I think it's happening all over, not just healthcare. I mean, these kinds of systems are automating all kinds of rote tasks exactly. that human beings do. Yeah.
So I've got a question for you. For the students in the audience who might be interested in entrepreneurship, what should they be doing and thinking about to help them develop their ideas for new companies? You're doing this yourself, and you've gone through this whole pathway. So if you could talk a little bit about that, I think it'd be interesting.
Sure. Well, the first thing to do, I would say, is really believe in yourself and in your idea. That's kind of like, you got to start there. And that comes from talking to people, talking to experts. Go reach out to your professors, find out, I know that you have an entrepreneurship program, go find those people and start to talk to them. That you should do from the moment you start thinking, I think I have an idea for a company. You really do want to start to talk to people. The second thing is most companies are founded by groups of people, not usually so much by individuals. And there's a reason for that. And that is that you need a lot of different expertise in order to make your idea into a reality. You may be an engineer and you're very good at this one thing. And maybe you need a clinician and somebody who's going to really understand how it's going to be applied. And you may need somebody who's going to really understand the business aspects. So recognizing that you are going to probably be good at one of those things, and finding your cohort, finding your collaborators you can lock arms with and move together, to represent a lot of different things is also really important. So I'd say those two things, start talking to people early and find your co-founders is a really important thing.
Well, that's a very interesting response in the context also of, what we're trying to do with the College of Health, which is a really integrated approach to learning. And, not just College of Health individuals, but College of Health and the College of Engineering and Arts and Sciences and whatnot, and the opportunity to put together dual degrees, a minor and a major, and get that broader perspective. So as you reach out to these folks, you're in a much, much better position to kind of holistically think about that idea and bring it forward and actually interact with those folks. So I think that's a really great recommendation. Let me move to a more technical question for you. Sure. And this is a really interesting one. And there are several open source domain-specific NLP models capable of routine NLP tasks like entity recognition and linking and text summarization, et cetera, et cetera. For the NLP models underpinning Astrata's platforms, are any open source models leveraged at all, or are they all proprietary?
Very few, unfortunately. Every once in a while, we'll use something that's open source. It's more typically, a modeling advance. BERT comes to mind. It's a deep learning modeling technology. But in almost every case, certainly with the machine learning methods, we're retraining these methods. If we're using something that is open source, we're retraining them with our own data. For the things that you mentioned, things like, entity recognition, et cetera, for the NLP pipelines, I mean, you can buy these from Amazon, for example.
Right.
No, we are not. And the reason is that clinical data is actually, it's very different than other types of data. The language is very different, and it's actually composed of a set of sub-languages. And each of those measures that I showed you is almost like a sub-language. And therefore, the sort of standard out-of-the-box stuff does not work very well, unfortunately.
Wow. That's too bad. So here's an interesting question. If NLP can help in terms of looking at these documents, can it be used in real time to actually generate the reports? They've got a new physician, and so they don't have to spend all of that time.
Yeah.
How does that work?
Right. Great question. So certainly prior to the EMRs and the requirement to select everything in a drop down or a radio button, voice recognition was, the big thing, and physicians and providers of all sorts were just dictating their notes and they would magically appear as clinical notes. And then once the move to EMRs came from providers, that really kind of had to change to sitting down and picking the thing out of the drop down. The really cool thing, I think, is coming, which I think is kind of what you're alluding to, and maybe what the questioner is alluding to, which is, could I just sit there as a provider? My patient is in front of me. I do everything with my patient. And then I basically just dictate what is going on. I say, Mrs. Jacobson is here for her hypertensive medication and she's doing well, and blah, blah, blah. And that would actually select the things from the drop downs and put it automatically into structured data. Yeah. I think this is possible, although I think it is going to take time. There are a number of companies that are working on this. And I'm thinking of one called Soku, I think is the name of it. Bridge is another one. Mm-hmm. So there's definitely innovation going on in this space. And I think it is going to be very exciting. And for the providers, this is exactly what they want. I mean, they really do not want to be sitting down at the EMRs and doing this. So what you just described, and I think what we're talking about here, would be an incredible advance for providers.
It would be a grand slam.
It really would. It would be.
If anybody on the call has an idea on how to do this,
this for your design thinking.
You can talk to Rebecca. You can talk to the folks at the Baker Institute, and we could all get behind that one. Be fantastic. So let's talk a little bit about risk here. Okay, so if you get this wrong and the patient outcome is wrong because the diagnostic is wrong and whatnot, how do you think about managing that risk, and how would the organization that is using this, the hospital system or whatever, think about that risk and try to mitigate it?
Great question. So the good thing about programs like HEDIS is that they have audit mechanisms built into them. Mm-hmm. And HEDIS, the health plan, this is what we've been working on, has concepts around and actually goes in with auditing firms, and they're HEDIS auditing firms that will go in and they will say, they'll pull 30 records and they'll see, which ones were done correctly and which ones weren't. Well, NCQA is going to probably, first of all, NCQA, which is the owner of HEDIS, the developer, the steward of this measure program, is mm-hmm. going to, in the near future, probably in the next year or two, have a way that natural language processing systems can be certified. Mm-hmm. And in order to get certified, you have to pass a yearly standard where they will come in and they will basically audit you, kind of similar to what they're doing now. So part of the answer to that question is that the programs themselves need to have kind of auditing programs worked into them, woven into them. Right. The second thing is that we as a company are constantly, looking at our data with our customers, evaluating it, measuring our precision. I mean, I went very quickly through it because we didn't have time, but our company measures its accuracy at many different levels, including when a system is in place to make sure that it stays accurate, which is actually also very important. Mm-hmm. So the short answer is the programs themselves will have audits associated with them, and we will be required to meet them in order to use this data.
That's great. So I'm going to do one more question with you, and then I'll turn it over to Beth. So I'm going to flip that question around and say that, do you see a time where the insurance companies, whether it's the federal government as the payer, or the private insurers are actually giving discounts for using this technology correctly. I personally could.
Yeah. I think there's going to be a lot of innate pressure to use these technologies, because if you don't use them, your rates are going to look bad compared to your competitors who are using them. And that, I think, just the competitive pressure there, because, you know, these health plans in particular, I mean, when the STARS ratings come out from CMS, you know, the health plans, they really care about what those things, and not just because of the money that's associated with them. And there are, you know, millions of dollars associated with it. They really care because it is an indicator of their quality. So there's a real kind of, you know, desire to do well because it's an indicator of the quality of the health plan.
Well, thank you very much. It's been a great conversation with you. So thank you on behalf of everybody on the call. And I'm going to turn this over to Dean Dolan. So
thank you so much. I really enjoyed it.
So did I.
That was such a great conversation. Thank you so much, Vince, and thank you so much, Dr. Jacobson. If I could ask just one more question, maybe for students who are listening. If there's students in the audience who want to work for a startup company, what do you look for when you hire new employees? What would you want them to bring to the table?
Sure. So first of all, this is a great time for new students to be hired by startup companies. There is a real labor shortage out there, and sort of the traditional, you have to have worked in the industry for a year, has gone out the window. So you all are very, very interesting to startup companies right now. I would say that certainly having done an internship, that is something that is really important. So I know that there's opportunities to do that through your college, et cetera. Really seek those out. That's probably the single most important thing that I would say that you can do that will differentiate you. I think the other thing is, you know, making it clear, you know, trying to sort of individualize. If you're a data analytics person and man, you really are interested in predictive analytics, you know, go find those companies that are doing predictive analytics and tell them, you know, I took this course on predictive analytics. This is why I love it so much. This is why I think this is my passion and I want to make my career doing predictive analytics. That is going to really resonate with them. People, you know, having that kind of connection to what a particular startup is working on. So those are the two main pieces of advice I would give.
Well, that's fantastic advice. Really appreciate that. So I'm just going to wrap things up here with a few announcements, but just want to thank you. And again, we're giving you a hand, although you can't hear it. Yeah, thank you. Really, it was fantastic. For everybody on the call, all the Lehigh folks, just want to invite you to the Opportunity Room on Friday, October 29th from 12 to 1:30 to do some of this imagining, you know, of things that spark your interest, that you're passionate about, and start thinking through how can you fit that into the world of opportunity. I also want to point everyone to our next colloquium. So if we could have the next slide, that would be great. So our next colloquium will feature Dr. Steve Tang in conversation with our very own Anand Jakota. And that will be December, I'm not seeing the date on here, but I believe it's December 4th at noon. Am I missing the date? Yeah, don't see it. Anyway, I think that's the date. And then final slide. We also are really excited to share with you that we are currently accepting applications for our first cohort in our graduate programs. That cohort will start in the fall. And if you decide to apply this year and you make it in and you're in the first cohort, we're giving you a 50% tuition discount. So that's pretty exciting. If you want to learn more about these programs, we actually have an information session today at 6:30 p.m. And there's some information down there at the bottom about how you can register for that information session. If you attend the information session, we waive your application fee. So we're clearing all the obstacles for you to come join us. So thanks everybody so much for participating today. Thanks so much to our speaker, Dr. Rebecca Jacobson, and also to our friend, supporter, alumni, Vince Forlenza. Really appreciate it.
Dean Dolan, December 4th, it's a Saturday. So
that can't be right then.
That can't be right. So we'll get back.
Yeah. Yeah. Well, it's December 1st. December 1st is the date of that talk. So our next colloquium, join us on December 1st. All right, thanks everybody.
Bye.
Bye.
So long.